Hello, everyone, and thank you so much for attending our Woo You event, Focus on the Lids for OSD Success. And I am your host, Dr. Stephanie Woo, and the founder of Woo University. And now it's my pleasure to introduce our speaker for this evening. Dr. Barnett earned her Bachelor of Arts degree in psychology and a minor in chemistry from Smith College. She received her Doctor of Optometry and completed a clinical teaching fellowship from the University of Berkeley School of Optometry. She is a principal optometrist at the University of California and an internationally recognized key opinion leader specializing in dry eye and specialty contact lenses. Together, Dr. Barnett and Dr. Lynette Johns authored and edited the book Contemporary Scleral Lenses, Theory and Application. I personally have this book and it's excellent. And Dr. Barnett holds many credentials and accolades, such as the inaugural Thea Award for Excellence for Mentoring by Women in Optometry, and she was granted the Most Influential Women in Optical from Vision Monday in 2019. Dr. Barnett is joining us all the way from California, flew into Las Vegas. All of the Woo You attendees online know and love her, so welcome, Dr. Barnett.
Thank you so much, and so great to be here in Las Vegas, and hello to everyone online. So thank you for joining us tonight. I know it's a very busy time of year, so really appreciate you being here with us. These are my disclosures. Very fortunate to help grow this wonderful industry that we have, and I have nothing in this presentation that will be specific to one company or another. So we have a lot of fun stuff to cover. So those of you in person, if you have anything specific you really want to cover, let's do it. There's a lot of information in this lecture, but I do find it very clinically relevant and things that I use in my practice every day. So let's get started just with some fun here. So thanks to Dr. Laura Perriman for that, because, you know, we're going to start talking about Demodex. So Demodex is actually a very highly prevalent condition, and it's underdiagnosed and undertreated. And here you can see the Colorettes, and hopefully you can appreciate the Colorettes there. And it is really associated with many different anterior segment conditions. So there's Demodex follicularum, so the larger ones, 0.3 to 0.4, and brevis, which are smaller, which reside in those sebaceous glands, which are about 0.2 to 0.3. And I don't know if any of you have a microscope. Do any of you have a microscope where you're actually epilating lashes and looking at Demodex? It's kind of fun if you want to. You don't have to at all. I know, just as the food coming out for those in person, right? We're talking about Demodex. This is great. But both adult mites have this cigar shape with the four legs to grip onto those eyelashes, and you could see it if you wanted to with a microscope. I find this slide to be really interesting because there are many different mechanisms how Demodex affects the ocular surface. We have the mechanical way where the lash distension occurs as the Demodex mite attaches to the follicles. We have the bacterial. I think that's the most common in my mind. I'm always thinking about blepharitis and Demodex and meibomian gland dysfunction, and how Demodex mites actually contribute to blepharitis by carrying that bacteria. And then we have the chemical, which is really interesting when we're talking about meibom. And I have so many patients who have ocular rosacea, and they also have Demodex, and that comes to mind when we talk about the chemical component. So it's actually really interesting how many patients have Demodex, and I'm going to show you some studies in just a moment. But there is a strong correlation between Demodex and many different ocular conditions. blepharitis, just highly, highly prevalent. And so what I'm writing now in my chart notes is I'm writing the Colorettes and actually grading Colorettes. And in addition to blepharitis and meibomian gland dysfunction, the eyelash alterations. Now, this is so interesting. So if you have a patient, either have them look down or close their eyes and look at their eyelashes. Do you ever see their eyelashes and they look like little triangles? So they're not going straight down? Demodex. If you ever look at the eyelashes just looking down and they're misdirected, trichiasis. This is a true story. Yesterday, I was in clinic and I used every single pair of forceps that we had in our clinic because I had so many patients, either for trichiasis or punctal plugs, whatever it was, that we were out in the entire clinic yesterday. That was a fun one. Conjunctivitis, keratitis, and also correlation between basal cell carcinoma of the eyelids. Now, what I want you to kind of take home and bring back to your practice tomorrow, because I will want you looking for Demodex tomorrow in practice, is this one statistic here. I'm going to share many, but this one is that 69% of blepharitis cases are due to Demodex infestation, leading to Demodex blepharitis. So if you have a patient, you're having them look down or close the lids and they have blepharitis, look for Demodex, look for those Colorettes, because you're going to see it in the majority of your patients. We know that there are many other things that Demodex is associated with, including acne. I'm not going to go over every single thing. And here you can see the differences in the sizes of Demodex as well. Now, I've been learning a lot over the years when researching Demodex, and I do want to share with you the itching, because itching, we always think allergy. But now I've come to ask my patients, where are your eyes itching? Is it the eyeball itself or is it the eyelid? Because there's a big difference there. So those who say, oh yeah, it's my eyelids and lashes, that's the part that's really itching. Then I think, oh, that's not allergy, that's Demodex that I'm looking for. So I'm looking more closely for Demodex. And it's really fascinating if you just ask your patients, where do your eyes itch? Because people say, oh, they itch, but ask specifically, where do they itch? And you'll see if it's an allergy or if it's more of a Demodex situation there. The eyes that water all the time, redness. Redness is so common, and not even just in people who are older, but in younger patients as well, where their eyes are red, they're not white, they don't look as well as good as they want them to look. And I think all of you know who are practicing, we can have patients who are completely asymptomatic, who have no symptoms at all, who have horrific Demodex. Okay, live folks, have any of you seen this where you see so much Demodex and the patient's like, my eyes feel fine. Thank you. Yes. Yeah, it's really actually quite common, which is interesting. And there's a poor correlation between the symptoms and Demodex infestation. So here we can see the Colorettes. And when you go back to practice tomorrow, all of you, I want you to look for Colorettes. I will challenge you for your next 10 patients tomorrow, have them look down, close their eyes, and look for Colorettes. I don't care if it's an 8-year-old kid or if it's someone who's 20 or 95. Look for Colorettes, and I think you're going to be really surprised on how many you actually see. And the Colorettes really have that mite waist, and we can elaborate on that, but it's dinner time, so we're not going to do that. But we know that 100% of patients with Colorettes do have Demodex blepharitis. And it is very easy to diagnose Demodex. So you can simply have your patients close their eyes or look down. Now, there's a little bit of a debate. Do you have your patients close their eyes or do you have the patients look down? So I'm in the camp of closing eyes. Let me tell you why. Because it's much more than Demodex that I'm looking for. I'm looking for lagophthalmos. I'm looking for incomplete eyelid closure. I want to see their eyelid position as well. But you could do both. You could have the patients actually physically close their eyes, not real tight, but just gently close them, or you could just have them look down. But if you have your patients look down, it's really easy to visualize the Demodex on their eyelashes. In Colorettes, if you just, if you look at your patient just straight on, it's really hard to see them. But if you have them look down, it's much easier. Now, this was a study. This is a really interesting study of over 1,000 patients. And these were consecutive patients. So just one after another after another. I was fortunate to participate in this study. And I work at a few different locations. So some of you know, I work in a student age population and a college age population. I have a general disease-based practice, and then also like a specialty and dry eye practice. So across all these practices, I was just looking at all the eyelashes and marking off Demodex. And I learned from this study from participating in the younger age population. I was very surprised how many patients have Demodex. So in really every patient now, I'm looking for Demodex and addressing it. I saw an 8-year-old kid yesterday, and he actually had Demodex as well. So in this study, it was an optometry and ophthalmology study looking at the percentages of those with Demodex blepharitis. It was 58%. And with a dry eye diagnosis as well, it was 58%. Now, there was a different study I did not participate in with almost 200 patients in New York and looking at the percentage of the overall population with Demodex, 55%, and with dry eye, 68%. So in many patients who have dry eye, and maybe we've tried a lot of different things to address the dry eye and that ocular surface, maybe it's Demodex that we could be addressing and helping to help our patients, and especially those who wear contact lenses. So I'll show you some studies there in just a moment. So in the studies, we're looking at patients with different conditions. So cataracts and cataract surgery patients, 56% of patients had Demodex, those on dry eye prescription management, 60%, glaucoma, 65, MGD, 57, contact lens wearers, 51, which is lower than some other studies, and ocular rosacea and facial rosacea, 60%. So a very highly prevalent condition here. So many of you know, I love contact lenses, and here we're talking about all types of contact lenses. So soft contact lenses, specialty contact lenses, and this could be a real game changer, I think, in how we treat our patients moving forward and those who wear contact lenses. So these are all studies looking at soft contact lens wearers and looking at daily contacts, cosmetics and glasses. They might be influential. So this study was in Asian females. The average age was 27. There are 20 contact lens wearers, 20 who did not wear contact lenses. And here you can see Demodex was present in 90% of soft contact lens wearers. This is age 27. Okay, I think that's pretty young. And 65% of those who did not wear contact lenses. That's amazing. Now, throwing another study at you, here we can see that contact lenses were present in 93% of wearers with contact lens intolerance. We all know the whole cycle of patients, right, who drop out of contact lenses. We have, I think, the best technologies and here I'm talking soft contact lenses. We have the best technologies now that we've ever had. We have super advanced daily replacement contact lenses, and patients are still dropping out of contact lenses. And we know that it's very important for patients to be comfortable with contact lens wear. We want to make sure that they're comfortable, that they see well. And if we could somehow prevent contact lens discontinuation and dropout and keep our patients in contacts, that's going to help our patients most definitely, but also our practices as well. So in this study, Demodex was present, and it could potentially so we're looking at different studies. 80 to 90% of patients who wear soft contact lenses have Demodex. And if we can address Demodex, perhaps we could keep our patients in contact lenses. Now, in this lecture, I feel like I'm talking about the psychological impact of multiple conditions. It's not all on Demodex, but I do think it's important to really address this with our patients, because why are our patients coming to us? They're coming to us so that they can see better and also feel better as well. And looking at this study, the negative burden of Demodex blepharitis, it's very significant. So 80% of patients reported a negative impact on their quality of life. Itchy eyes, dry eyes, foreign body sensation, watery eyes. And so that's a good way to diagnose Demodex earlier. How many of your patients are unable to wear makeup? I find that to be very, very common, and we'll talk about that later in this lecture. But those who have Demodex find that they are unable to wear makeup. The difficulty driving at night is quite interesting, because in my mind, I'm always thinking cataracts. It's cataracts, that's why you're having a hard time driving at night, or macular degeneration, but Demodex is also associated with that. And the negative appearance of the eyes and constantly worrying about the eyes, these are all things associated with Demodex. So the current methods that we have now, we're kind of, doing all sorts of different things to address the eyelids, but we don't have an FDA approved product, and we don't have something that's specifically targeting Demodex at this point in time. So we will hopefully soon have a product to address Demodex. So TP03 is going through the process. So the NDA was submitted, and I did hear today, I think it's August 25th of 2023 is the magical date that we're looking out for. So not too far away. And I know that I'm telling my patients now that we don't have this specifically, but looking forward to the future, and hopefully the future is a little bit sooner than later. So lotilaner actually is a non-competitive antagonist of mite, and it just kind of snaps and kills those Demodex mites. And I do have a video coming up here too. So there were two pivotal clinical trials, which were very important. So Saturn 1 and Saturn 2. And I just want to show you a few points of the data. I love pictures, right? And here's some great pictures. So we can see on the left-hand side, the grade 4 Colorettes. So you can see 2/3 of the lashes, approximately 150 Colorettes. Do you want to count those Colorettes? No, no. But looking at grade 3, about 1/3 to 2/3 of lashes have Colorettes, so about 100. And then you can see the grade 1 and the grade 0. So grade 1 has less than 10, and 0 is just complete eradication. So no Colorettes, they're all gone there. And the chances of Demodex obviously increase with more Colorettes, because if we have Colorettes, we definitely have Demodex blepharitis. So here you can see the arrhythmia scale. Look at that. And how many of you just think of a patient you had today who looked like that? I can tell you, yes, thank you for nodding, because I had patients I see who look like this all the time. And now I'm thinking, oh yes, that's probably Demodex, where 5 years ago, I wasn't at all. So here we can see the severe, moderate, mild, and no arrhythmia there. So in the studies, we have a similar number in the TP03 group. Again, these are the Saturn 1 and 2, the pivotal studies. So in the TP03 compared to the vehicle, and the goal here is really getting rid of all of those Colorettes. We're also looking at the mites per lash and eyelid or eye arrhythmia as well. So here you can see the primary endpoint of complete Colorette cure. And so 0 to 2 Colorettes. You just saw some of those pictures with 150 Colorettes. So 0 to 2 is a huge, huge improvement, right? And you can see the Colorette cure. And this is just looking at the two different studies here. But you can see the vast improvement with TP-03 compared to the vehicle in both of those studies. Here we're looking for a clinical meaningful Colorette cure, less than 10, achieved in both studies as well. And here you're looking at the endpoint of eradicating those mites, so getting rid of those mites. TP-03 again compared to the vehicle, far improvement here, statistically significant once again. And that arrhythmia cure, you saw those pictures of the arrhythmia. Again, the TP-03 compared to the vehicle, statistically significant once again. So we do need to go over the adverse events that did occur in these two trials. So you can see the installation site pain, burning, stinging in the TP-03 compared to the vehicle. Look at that vehicle at 7.7% compared to TP-03, which is almost 12%. In Saturn 1, Saturn 2, we have 7.9, TP-03, 6.7 vehicle. I would say those are pretty similar. We have some installation site pruritus, reduced visual acuity, which is quite interesting, but it is in both TP-03 and vehicle groups. Eye pain, dry eye. If you look at all the severity, really that's the most important thing. So these adverse effects were very mild, some were moderate, and not severe. Over 90% reported the drops to be neutral to very comfortable. So that's important. So TP-03 is actually an eye drop. I think that's important for us to know. It's not an ointment or a gel. It's an eye drop that is used and is very comfortable by patients. So let's watch another fun video. So that's great, right? Bye-bye, mites. So the key takeaways, I think I covered this, is that tomorrow I want you all to go look at your patients, look for collarettes, have your patients look down or close their eyes. In patients with blepharitis, Demodex is so highly prevalent. We don't have exact mechanisms right now to address Demodex blepharitis, but we will in the near future, which is very, very exciting. And I'm particularly excited for my patients who wear contact lenses to be able to keep them in contact lenses, but really for everyone too. We can help them make their eyes feel better and look better. And it's going to be really fun and a great new product that is coming soon. So moving on, because we're focusing on the lids, we're focusing all on the lids. Now we're moving on to meibomian gland dysfunction. And we know the meibomian glands, I don't want to go over the anatomy too much here, but the mechanism of blinking. How many of you are telling your patients to blink? Are you telling them to, oh, good, yeah. I feel like sometimes I have to tell myself to blink too, because we're all on digital devices so much. But the mechanism, so actually contracting the orbicularis oculi muscle, compressing that tarsal plate and that milking action is really important for our meibomian glands. And we're all on digital devices more than ever before. This is my new way of examining patients that I do want to share with you, just in general. So before I'm diving into the slit lamp routine and looking at them with a really super bright light, and I learned this from evaluating patients who wear scleral lenses, because I find that if I can look at them just from a little bit of a distance there, then I get more information. How's the lens landing? Is it blanching? Is there impingement? But now what I'm doing is I'm looking at my patients from across the room saying, do they have floppy eyelids? Perhaps they have sleep apnea. Does it look like they have diabetes or rheumatoid arthritis or rosacea? There's a lot of information we can get, but we can also get eyelid position. We can look at their eyes and look and see if they're red. Do they have eye arrhythmia, or are they nice and white? Are their eyelids open? So there's just a lot of information we can get. This is also fun when you're just out and shopping and looking at someone from across the way too. You can get a lot of information about lots of people, but I find this to be helpful. Digital devices, we are all on digital devices so much. When I talk to my students and the student population, it's like a joke, right? How many hours a day are you on digital devices? And they sort of laugh, and then we talk about it. Okay, in the room here, how many, and just like shout it out, how many digital devices do you have? Do you use on a daily basis, and your watch is included? 3, 4, 5, anyone have 6? Okay, yeah, we are on digital devices. We're on electronic medical records all day, every day. I have 2 kids during the pandemic. They were home. They were on their computers doing school. Now they're back in school. They're still on their computers because their teachers require it. So we are all on digital devices more than ever before. That's really affected our lives and in most every age group, I would say. So here are a few studies showing us that when we're looking at screens, we're not blinking as much. And so it is important to go over with our patients how to appropriately look at digital devices. And some of my patients, at least, are not in their normal environment. So they're like in a home office, which is not really set up ergonomically. So their computer might be a little bit off versus at work. And it could affect their ocular surface as well. So we know that digital device use and dry eye go hand in hand. And this was looking at a study showing that computers and digital devices were associated with meibomian gland dysfunction. We know that those who are using high cognitive tasks, like I would say a lot of people, they can have a decreased blink rate. So they have a less of a blink rate versus those who are just watching like a movie or something like that. This was a study that the high cognitive task was actually looking at letters and pressing a space bar versus a low cognitive task, which was just looking and watching a movie, and showed that the task difficulty really had a lower blink rate. So how many of you are going over the 20-20-20 rule? Yay, most of you. That's great. That's so important. So I like to talk to my patients about this, and it's educational, it's fun, right? And most importantly, it can help our patients with their dry eye. So every 20 minutes, look 20 feet away at something that is not a digital device and blink eyes for 20 seconds. So I ask my patients, do you take breaks on digital devices? And they say, oh yeah, I take breaks. I say, okay. So how often are your breaks? Yes, they're every 3 hours or 4 hours, I take a 5-minute break. Like, that's not really a break. And I've also learned that some of my patients were taking a break, but looking at another digital device. So if possible, go take a walk, go outside, go do something different, take a little break. And I think it's very important to educate our patients on this. I actually write it down for my patients and have them, patients of all ages, and because then they can remember it. We also want to go over proper positioning. So looking down about 10 degrees, blinking exercises, adding in a desktop humidifier is very helpful, especially during these winter months. We can go over blink exercises, There's an app that has blink exercises if you want to as well. And you can add these really cute humidifiers, right? You can have a little cactus on your desk or a little plant. But this will help with the workplace humidity. And I'm thinking to myself now, I should probably add one myself. So I was hesitant to keep mask-associated dry eye in this lecture, but then I thought, well, we're still wearing masks. We're still having all of our patients to wear masks. And so it is a topic, and this whole fogging situation is still coming up, and the dry eye is still coming up. So I'm just briefly going to go over mask-associated dry eye. So we know that masks, face masks, and we know when patients breathe, when we all breathe, right? And the hot air goes up and it goes into our eyes, it can really dry that ocular surface. And how many of you have seen like the most styes and hordeolum ever then because of all these masks? Yeah. So like no one except me. Oh, sorry. I can't see all of you because of the lights. Just the three of you. So we've seen it so highly prevalently in our clinic, but we know that the air is really what's causing all these issues. And so there are tools and techniques that we can use, all of us, to help with mask-associated dry eye. So we can tape the mask, we can lubricate that ocular surface, and we are actually taping masks just a little bit for our patients in clinic because it's much easier for refracting using condensing lenses. But I think all of us at this point know that taking breaks on computers, hydrating, also quite important there. So now we are switching topics. So this is a video. Here you have a mother and her daughter. So these are their eyes side by side. And maybe it's not a video playing, but that's okay. So, nope, okay. Anyway, you can see how the mother and daughter, if the video were playing, how they're blinking and how they're blinking a little bit differently. But the point here that I want to draw your attention to is looking at their eyelid position, because now we're moving on to ptosis. So look at their eyelid position and see what you think about that. Oh, here we go. We have the video. Yay. So you can see it's obvious who's the mother and who's the daughter, but look at how their blink, and look at how their blink is a little bit different. Can those of you see it here? Okay, good. So ptosis, we know, is a low-lying position of the eyelid. Now, here you see the word droopy, but I never, ever tell my patients that it's droopy. I had an 85-year-old patient yesterday, and he said, oh, yes, you told me that my eyelid is droopy. And I told him, I would never, ever say that to you because I would not. I told him, and we made it into a very fun joke. He told me that his eyelid was droopy. I like to tell my patients that it's a normal change over time, just like presbyopia, right? Because presbyopia is really important too. So over time, our eyelid position can change. And there's congenital ptosis, of course, and there's also acquired ptosis. So kids can be born with ptosis. It can be unilateral or bilateral. It's oftentimes asymmetric. And as adults, we can often have ptosis as well. So ptosis can really obstruct the pupil. It can cause superior visual field defects. One of my favorite studies I'm telling my patients now is how the superior visual field, so not just the inferior visual field loss, like in glaucoma, but superior visual field loss can increase the risk of falls. And that's really important, especially for our patients who are going up in years. Ptosis can affect contrast sensitivity, dry eye, back to contact lenses again, because we always have to talk about that. But think about your patients, not only those who are wearing corneal gas permeable lenses, but those who are in soft multifocal lenses and say that their vision isn't clear enough. Is it their eyelid position that is getting in the way, where if we increase the eyelid position, allow more light to get into the eye, that they see better. So I've had patients who report, oh yes, I actually see better out of my soft multifocal contact lenses after their ptosis is improved. And then my corneal gas permeable lens wearers are actually really, really happy there too. Cosmetically, we can have that asymmetric, sleepy, tired look. That is a very common one. And I'm going to focus here mostly on acquired ptosis because we know it's a result of the stretching of that levator muscle or the disinsertion of the levator muscle complex. So it's the aponeurotic, which is the most common. And it can also be affected by many other things. And we could have trauma, anything urgent, anything neurological. Of course, that's an emergency. We need to address that. But we can have the mechanical ptosis where we have the excessive skin and the eyelid heaviness. We also have dermatochalasis we have to keep in mind as well. So the overlying skin and the ptosis, which often go, the lower eyelid, which often go hand in hand. So risk factors for ptosis, aging. Again, I'll never tell my patients that they're old. Contact lens wear. Looking at the studies of contact lens wear and ptosis, I was fascinated. I always thought, oh yes, in my corneal gas permeable lens wearers, of course, we're pulling. I'm a corneal GP, long-standing corneal GP lens wearer. I was pulling on the side of my eye to release the lens, right? We can do that to remove the lens. So in those patients, ptosis is very common. But what about your soft contact lens wear? So in the studies, it's actually showing that soft contact lens wear ptosis is highly prevalent as well. Any sort of ocular surgery. The most common, I think, is cataract surgery, where the eyelid speculum is holding open the eyelid, which can cause a ptosis. So if I'm sending my patients for surgery, for ptosis repair surgery, I'm going to have them hopefully do cataract surgery first and then do ptosis repair surgery. But this could be any ocular surgery, retinal repair, glaucoma surgery, etc. Any sort of underlying disease can cause ptosis. Botox, any injection can cause ptosis. I'm sure we've all seen that. And of course, trauma. It's a highly prevalent condition. So in the US, 13 million people over age 50 in 2020 had ptosis, and 1 in 10 adults over 50 have ptosis. I think that number is completely low and wrong. I think it's much, much higher if you're looking for it. And if you are aware about just facial ocular plastic surgery that's being done, there's more plastic surgery that is being done now. So the anti-aging market in the US is billions and billions of dollars, and the amount of plastic surgery is going through the roof because of all the virtual components of things where we're actually looking at ourselves on screens. And so I would include eyelids in that market as well. This group, those of you online, you all know this. If there is neurological disease, it is an emergency. We have to address the patient. If there's vision loss, if there are pupil changes, if the ptosis is acute, of course, we're going to address that. We're not going to say, oh, yes, you have this acute thing and we're going to do nothing about it. So in patients who have Horner's or myasthenia gravis or a third nerve palsy, we're definitely going to address that same day urgently. When we measure ptosis, this is kind of fun. I don't think we went over this in school, but we have MRD1 and MRD2. You can see the picture here. So MRD1 is the distance between the center of the pupillary light reflex and the upper eyelid margin. A normal range is about 4 to 5. The MRD2, you can see there. So you have the center, the pupillary light to the lower reflex. Levator muscle function, we have our patients look up and down. A normal range is greater than 15. And then that eyelid crease height, this is really interesting. This is something that I've been learning recently, is that we want to look at the eyelid crease height. How large is that platform? Because then we can play that into our diagnosis as well. A normal 7 to 8 in males, 9 to 10 millimeters in females. And of course, we can do visual field testing. We can do formal visual field testing to diagnose ptosis as well. I work with oculoplastics, and they will do a visual field definitely prior to any sort of ptosis repair surgery. Now, we know that ptosis really impacts wellness and vision, so patients might feel like they're not being received as well. A very interesting study, I looked at strabismus and ptosis. So actually having a ptosis and eyelid ptosis was just as equal or more so than having a strabismus as to how other people perceive you. So it can affect the psychological effects, anxiety and depression. And these numbers, I've looked at many of these studies actually, the numbers are very high of how ptosis affects anxiety and depression. So if you have a patient and you're talking to them about their eyelid position, please take it seriously, because you might think, oh, that looks like a mild ptosis. That doesn't look that bad to me. But in your patient's mind, it might be something that really affects their day-to-day functioning. Quality of vision, so it can address blurry vision, higher order aberrations, that superior visual field loss. And then when we have patients on different devices, right, computers, digital devices, and they have a ptosis and say they're looking through their progressive lens, and then they're doing some funny position where they have their neck is off or their back is off, it can cause all sorts of other conditions like neck ache and backache and headaches as well. So it's something that we do want to address. So prior to a pharmaceutical option, I don't think I was necessarily documenting ptosis so much, because if we had a mild to moderate ptosis, there wasn't much to do unless I could send the patient off to an oculoplastic surgeon for surgery. But we do now have a pharmaceutical option for ptosis. So Upneeq is that option. So it's oxymetazoline, hydrochloride. And when my patients say, well, how does this work? I do honestly say it's magic. But then I do tell them truthfully, it's an alpha adrenergic agonist receptor, and it has a 5-fold greater affinity for the alpha-2 receptors. So it targets Mueller's muscle to lift up the eyelid. And that's sort of how I say it. And then my patients look at me and they say, what? It's an eye drop to lift up the eyelid? And I say, yes, it's an eye drop that lifts up the eyelid. So it's been something that's been really fun, I'll say, to have in my practice to help my patients. And I'll share just a few stories. I can kind of go on and on and on, but I think I have some pictures here. So here you can see a photo, the one on the left-hand side, and you can see a patient with ptosis. And when they're taking the picture, I would encourage you, if you're using Upneeq, to have your patients take pictures and have them look straight ahead, put the drop in, and then 15 minutes later, look straight and just in the same spot and take the photo, and you can see the differences here. So we have the one on the left, she's not exactly looking in the same spot. But the one on the right, you can see a 45-year-old female, and she was out running and she took the photos herself. So you can see the vast improvement. Oftentimes people will ask me, well, if there's an asymmetric ptosis, do you have them use the drop in one eye or both eyes? And I will have them typically use it bilaterally because it's going to help with both eyes. But if you want to try it out, you can definitely try using the drop in one eye and then a few minutes later using it in the other eye if you want. I think awareness is getting out there. This product has earned all of these awards and been recognized in all these different magazines. But as an eye care community, I think sometimes we don't talk to our patients about it as much as we could. because we do have this great opportunity to really help our patients. And I didn't include a lot of the safety studies here, but Upne can be used every single day. It can be used safely every single day. It lasts different lengths of time in different patients. There's no risk of using it daily. Many people use it occasionally, which is fine as well. And there's no tachyphylaxis or any problems of discontinuing the drop. It can be used occasionally. I have a patient who sent a message last week and she said, "It's holiday season. I need my Upneek." And I was like, "Oh, that's cute. Yeah, you're going to parties and all that. So yes, you want your eyes to look good." So now we're moving on to kind of more meibomian gland dysfunction here and meibomian gland anatomy. So how many of you have meibography in your practice, live folks? Virtual folks, you can answer that in your head. Okay. Well, even if you don't have meibography, it's okay. You have a transilluminator. I know you have that in your practice. And using a transilluminator to actually look at the meibomian glands, you can get a pretty good view. So not quite as good as meibography, but you can get a good view of the meibomian glands, which is really quite helpful. So here you can see some expression of the meibomian glands. This is a video, which in the room here, how many of you express in your clinics? Okay, great. Yeah, so isn't it super fun? I love it. I find it very satisfying. So look at that. Right during dinner time, right? So another thing you can use your transilluminator for is looking for an incomplete eyelid seal. So this is the core Blackie light test, and this is something that's pretty easy to use. So you can, in a dark room, just place the transilluminator against the lid, look for any light coming out below. And this really does correlate with dryness symptoms upon wakening. So when your patients come in and they say, "Oh, my eyes are so dry," you can ask them, when are they dry? Are they dry in the evening, in the morning, all day long? Is it after you're doing something specifically? And this is just a kind of helpful hint that you can take back to practice with you. Now, what are we doing for our patients for their meibomian gland dysfunction, right? And for their dry eye and for their eyelids? There's so much that we're doing. Now, the warm compresses, this is the core technique, which is really not working all that well. It's the Rose method you can see at the bottom right. It's bundling a bunch of wet washcloths. If you have a lot of time, I guess you can do it, but they're really going to cool off, and that's not very effective. But this is a study. This is a study I tell my patients and I tell myself. So I think a commercial warm compress is quite important. And this study did demonstrate by using a commercial warm compress once a day, 51 subjects, most were female in the study, but it improved comfortable wearing time of their contact lenses. So I like to tell my patients, and I like to tell myself, to encourage myself to do my warm compresses as well, that I can increase my comfortable wearing time by doing a compress 10 minutes once a day. And that can also help prevent contact lens dropout. Now we have many methods to address dry eye. Here you can see a bunch of them. I think it's incredibly important for all of our patients who have dry eye to be looking at those eyelids as well. So looking at the blepharitis, looking at the meibomian gland dysfunction, looking for those Demodex, looking for the mites, and most dry eyes actually mixed mechanism, right? So we do have the evaporative and we have the aqueous deficient. And even in my patients who have Sjogren's, I think they have a mixed mechanism of dry eye. Don't forget about adding humidifiers in general, and also adding moisture release goggles, so nighttime and also daytime. So we can do that as well. I was talking to a patient yesterday, it's feeling very dry in my area. we have had some rain, which is great, but many of my patients are saying my dry eye is worse now than it was before. So addressing that, oh boy, that I don't know what happened on that slide, but there are a lot of products that are out there. And I think it's important to talk to our patients about makeup and skincare. And because men wear makeup too, they wear lotion and sunscreen. Yes, you do. On their face and around their eyes. So it is important to address products. So my favorite website that I like to tell my patients about is the EWG, so the Skin Deep. And just, you can tell them, hey, there's this website. You can look up the ingredients in your products to see if they're safe and healthy. There are multiple ingredients in makeup in this country that are not regulated that can be very harmful for that ocular surface and the meibomian glands. So I also talk to my patients about different products if you want to talk about that are helpful. I do recommend using commercial eyelid cleaners, not baby shampoo, which is very drying to the ocular surface. And there are many different types of products, and there are really a lot of very good companies out there that have great products to address the ocular surface. So for those patients who say couldn't wear makeup before, now they can wear makeup. For those patients who their eyes were red and irritated, now there are different products that can help them as well. We have all sorts of options here. So we can use, of course, antibiotics, steroids. We have a few different steroid options now that we can use for our patients, many different immunomodulators, as you saw. I do talk to my patients about dietary supplementation, and I think that is quite important. So not only omegas that are very helpful, but there are great studies looking at different omegas that can affect the meibomian gland dysfunction, but also talking about drinking water. And there are different studies on turmeric and how it helps with the ocular surface. I do share these studies with my patients as well. And the microbiome, I think, is the future of dry eye. And so we don't have it yet, but addressing the microbiome and how it can affect the ocular surface, how it can affect the lids is really going to be helpful. I do want to get to these slides because I think it's interesting, and this is also sort of the way we're going in the future in our practices. So instead of sending our patients home to do home therapy, we can do in-office therapy to address their eyelids. And we want to address both that inflammatory component and the obstructive component of the meibomian glands. So and everything else, right? So the Demodex, the Blepharitis, everything that I've been talking about. So it's kind of a multifactorial approach. And if we look at, what's the disconnect? So 87, almost 90% believe obstruction is a key component of meibomian gland dysfunction. And 71% say obstruction removal should be first-line treatment, but only 5% of patients receive any sort of thermal expression treatment. I think if we go back to other systemic conditions, like if we're looking at the arteries in our body, right, say specifically the heart, and if we want to clear that out, it's the same obstruction. So we can talk to our patients about that. And these numbers, I believe, will be rising, and they are rising. But we have a huge potential here, right? Because if obstruction is really the key, there's so many of us in our practices where we can help with this. I wanted to share this recent study that came out looking at TierCare versus Lipiflow. So 235 subjects were in this study. And it was looking at, and these were more severe patient populations. I think that's an important part of it. And looked at the study for 1 month. And here you can see there was a significant OSD score reduction in the TierCare group compared to Lipiflow. And here you can see the different bar graphs looking at how TierCare performed to Lipiflow, and it was very positive there. So for those of you who want to look at the study, again, it was in a severe patient population. There's some other studies coming out with like how long these treatments are lasting. So we're learning a lot now. Different studies are saying different things, but they're lasting a longer duration. Of course, it really depends on the patient. So when we're looking at the ocular surface, right, really focus on the lid. So hopefully you'll go back to practice tomorrow. You'll focus on the lids. You'll look for collarettes. You'll look for blepharitis. You'll look for meibomian gland dysfunction. And really looking at the ocular surface in a whole, so important for all of our patients, especially those who wear contact lenses as well. We do want to, I didn't focus a lot on staining or, kind of diagnostics, but of course we do want to stain the conjunctiva with lissamine green if you have it, the cornea with fluorescein. We want to be ruling out dry eye in every single one of our patients, and that's going to help our patients. It's going to improve their quality of lives, reduce economic burden, and grow your practices as well. So with that, I will open it up for questions. Really want to thank all of you for your time, your attention, the in-person folks, virtual folks.